With our antepartum hemorrhage, and in this section we are gonna be discussing placenta previa. So what is placenta previa? Basically this is when the placenta is implanted in the lower segment of the uterus. And this implantation can be partially or complete. So, which means that you don't, if it's partially implanted, you won't be reluctant to say it's placenta previa just because it's partially implanted and not completely implanted. So the causes of this, there is no exact cause, but they are sort of like risk factors. So maybe I can just try and draw it here. If this is the uterus, that's the cervix, and that's the vagina. So you've got the placenta that is here, and then you've got, sometimes it can go like that, implant like that. You can just take the whole place. So, but we are going to talk about the different positions it can take. But basically, you've got a placenta that is lying on this side, not here on that side. It's not fundal, it's not up there. So in terms of there are certain conditions or situations whereby they are thought to play a very huge role in the development of this, and those can be endometrial factors, endometrial. They can be endometrial, they can be placental, and they can also be conceptus related. So under endometrial can be things like uterine scarring, repeated or excessive curettage, uterine scarring, or even congenital uterine malformations. It's nice to categorize things because it's easy to remember them. Placental factors would be things like just a very big placenta, placentalomegaly, or just an abnormal formation of placenta. And then conceptus related delay in the development or maturation of the fertilized ovum. Delay in the maturation or delayed implantation of that fertilized ovum. But the most common ones, these are the most common ones. So it's important when you are doing dilatation and curettage that you don't excessively use force and scrape a lot of that myometrium away. And when it comes to uterine scarring, you know, things like someone has done a lot of C-sections and someone who has done some other operations on the uterus, they will develop scars, or they can develop scars. And then there are things like things that they call predisposing factors. Predisposing factors. Predisposing factors: multiparity, advanced maternal age, so it's more likely to occur in a multipara than in a nullipara. Advanced maternal age, like I explained earlier, that previous C-section, myomectomy, basically any operation that was done in the uterus can leave a scar there and predispose the patient into developing this placenta previa. So and also previous placenta previa, the fact that you had it before, you can have it again. Previous placenta previa. And we did talk about uterine malformations. Uterine malformations. I can't think of anything else now. Yeah, so let's talk about now how it presents. Or maybe before that, let's just talk about the different positions this it can assume. So okay, complete is the easiest to draw. So that's our umbilical cord, and that's how it goes. So basically that's our placenta. It has completely obstructed the internal os or the cervix. That's a complete. And then the other one, it could be something like this, maybe up to halfway. Other one can be something like this. I don't think there's anyone who would ever ask you to draw this, guys. So we said it's a lower segment. So like I said, that for us to call it a placenta previa, it doesn't have to obstruct the cervix completely. As long as it's in the lower segment, it's already a placenta previa. So, and we can already see the dangers with this is that, first of all, the head or the presenting part in this case it will be on the other side. So which means this baby, if this baby has got to come out, the baby cannot come out here. And if the baby has got to come out, it means the baby will disrupt its own blood supply before it's even out. And by the time it comes out, it's already cyanotic, and now you need to resuscitate. That's why this thing needs to be operated. So the most important thing is that with us, any PV bleeding patient and any PV bleeding patient and antepartum hemorrhage, PV exam is not done, because once you do a digital exam, you can do PV exam but not digital, like inspection, that kind of thing. But putting your fingers there into that cervix, if it's a previa, you are likely to push against it and start to disrupt it in these corners. Now you will be forcefully separating it, and the bleeding will just be worsened, because you would have detached it forcefully here. And when you do that, you're already having PV bleeding, so it's gonna be worsened. That lady can quickly go into shock, even though when they came to you, they were not in shock, they were just bleeding. Another thing is that if you do a PV exam here, once you separate the placenta from there, even though you won't separate the whole of it, but once you separate it, you are sort of like cutting blood supply to the fetus. So that's why you don't want to, you want to put a speculum there. You don't want to put your finger in an antepartum hemorrhage. That's the reason why. Okay, so this is your grade 1, your grade 2, your grade 3 placenta previa. Okay, so how will a patient with placenta previa actually present? So like we said, it's going to be that patient who's pregnant. They come in, they've got PV bleeding. As we have said, they're in their reproductive years, and then they have got a positive pregnancy test, or they are pregnant, and we have confirmed that they are more than 24 weeks. So the PV bleeding that they will come in with, it's going to be a painless, very important, it's a painless PV bleeding. And this differentiates, we're going to talk about the other conditions later on, but it differentiates this from a lot of like uterine rupture, things like that. So it's painless PV bleeding. And when you do the abdomen examination, it's gonna be, the uterus will be soft and not hard. So it's just gonna be soft. It's gonna be non-tender. So these are very important features that they will ask you in the exams. So make sure. So contractions are plus minus. Plus minus. And also the presenting part will be high. So it will not be engaged. The presenting part is gonna be high, not engaged. This poses a risk. So remember, the most important thing, no digital exam. You can do a PV exam, but not digital. No digital exam, meaning putting the fingers there. This poses a risk on the fetus, like we said, and check. So it means you must check the fetal well-being and check the maternal well-being as well. So what we are learning, guys, is that when you have got a PV patient, after doing the abdominal examination, obviously we have stabilized the patient. So the next thing, since we're not going to do a digital PV exam, the next thing that is important is ultrasound. The ultrasound becomes very important. But obviously the patient has got to be stable. Why do we have to do an ultrasound? Ultrasound will, first of all, we want to know the location of this placenta. If you have got a PV bleeding patient, you suspect placenta previa, you go and do a scan, and you find that your placenta is in the fundus, or is high lying, it's not a low lying placenta, maybe it's fundal, then it means it's not placenta previa. Look for another diagnosis. So we look at the location of the placenta to confirm or dispute our diagnosis of a low-lying placenta. After checking the location of the placenta, we check the fetal well-being. Obviously, this baby must have a CTG, and then you'll just look at where the baby is, the lying part, position of the baby, fetal heart activity, the position, the lie, that kind of a thing. And yeah, because you don't know. So ultrasound is very, very important, because you cannot diagnose Previa by any other way except by doing that ultrasound, because ultrasound will make you to be able to visually see the location of the placenta. What am I missing here? So let's quickly talk about the complications. complications, we're going to divide them into maternal and fetal. So maternal would be a major APH can take the mother into shock, and then they can die from that. Say death. That's one. Number two, because of the antepartum hemorrhage that they have, they're at a risk of developing PPH after they have delivered. So which means as a treating doctor, you must look out for PPH and it must not surprise you. So PPH, they can even have anemia. Now they need transfusion, and they can have coagulopathy. Now if they start having low platelets, now when they bleed, they will bleed. And then I'm sure there are others. These are the ones that I can think of at this point. And then in terms of fetal, it can cause prematurity. It can it's a risk factor for abruptio, right? So you can have fetal insult like HIE, and because remember, once the blood, the oxygen to the baby and the nutrients becomes affected, then that brain has got a chance of being damaged. HIE, CP, and even intrauterine death. So those are the complications. We're already 23 minutes into this one. Thanks guys, let's meet on another video. Thank you.